Hi everybody, this is your supplemental lecture for head and neck. When you're doing your review of systems, some common or concerning symptoms that you want to be aware of. If the patient complains of headache or any history of head injury, in a history whether it being they're coming in for it now or at the same time if they've had it before. Because say for example if they had a head injury that resulted in a concussion, they are more likely to have increase in concussions as time goes on. Any visual disturbances, if they're having any spots, we call those scotomas, feelings of or visions of flashing lights. Do they use glasses or contact lenses? Do they having any eye pain, any erythema or redness, any excessive tearing, or on the flip side, any excessive drying, or if they're having any diplopia or double vision. If they're complaining of hearing loss, ringing or tinnitus in their ears, the sensation of vertigo, any pain or discharge. In the nose, looking for any type of drainage, whether that be clear drainage, purulent drainage, or even blood, whereas epistaxis. Looking for any congestion and even sneezing. And the oropharynx, sore throat. Of course, this is any of these things that they complain about, you definitely want to then go into more of a detailed physical exam in these areas. Any bleeding gums or hoarseness, and in the neck, if they have any swollen glands, any lymph nodes, or even a goiter. With inspection of the head, looking for hair distribution and quantity. Also at the scalp, any scaling or nevi that might be present. Looking for the size, shape, and contour of the skull. Looking at facial expression and contours of the face. Also looking for symmetry here. When it comes to skin, looking at the color of the pigmentation, any hair distribution or lesions that might be present. You're going to palpate the head, again, being able to feel that hair texture, looking for and feeling for any lumps or bumps in the skull. I'm going to palpate all the sinuses, and then being able to check the texture and temperature of the skin. When you inspect the eyes, you're looking at position and alignment of the eyes. Are they too close together? Are they too far apart together? Are they where they should be? Looking at quantity and distribution of hair on the eyebrows. You want to assess the eyelids, looking for the width of the palpebral fissures, any edema, discoloration, or any lesions. Some will have skin tags or other potential growths on their eyelids here. You want to look at the condition and the direction of their eyelashes, and at the same time, are they even present? Looking at the adequacy of the closed eyelids. And think about this too when we go over in the nervous system, or when you review the nervous system. Here you can start to do your cranial nerve assessment when you're also looking at the head and neck areas. The lacrimal apparatus, checking the lacrimal gland, and the sac, looking for any swelling or discharge. Looking at the color and vascular pattern of the conjunctiva and sclera. Here you might start to find signs and symptoms of conjunctivitis, for example. Looking for any opacities of the cornea and lens, glaucoma, for example. Or you can also, say if they were complaining of pain, you might assess for a corneal abrasion. Checking the clearly defined markings of the iris, and then looking at the pupils, looking at the shape, the size, looking at symmetry, and then reaction to light, so your perla here. Now, also, when it comes to reaction of light, you want to do direct and consensual, both direct and consensual, as you'll see on your advanced OSCE. When you're assessing for visual acuity, what you're doing is you're checking for the sharpness and clarity of their vision. So in terms of central vision, you'll use a Snellen eye chart, and that's the one that you're going to have the patient standing 20 feet in front of the, or 20 feet away, from the chart. Of course, if the patient wears glasses or any type of corrective lenses, you can use those here if needed. And you want to test one eye at a time, and then obviously both eyes at the same time lastly. So what does it mean when a patient is 20/20? So they can see at 20 feet what a person with unimpaired vision can see at 20 feet, so that we consider that normal vision. Now let's say if a patient had 20/100, what does that mean? So that means the person can see at 20 feet what a normal unimpaired vision person can see at 100 feet. So make sure you know the definition, I guess, of what does it mean if a person's 20/20 or 20/100, for example. You can also check for near vision, and you can use that handheld card that you got in your lab bags during these fall immersion. And you can use that to test visual acuity at the bedside as well, just making sure that you hold that chart at 14 inches from the patient's eyes. Looking for visual fields in the peripheries, you want to test both eyes at the same time, starting in the temporal fields. Now, if a patient has an issue during this assessment, then you want to test one eye at a time. Here, you can also be checking for your extraocular movements, also part of your cranial nerve assessment, using the 6 cardinal directions of gaze. So you'll normally have a normal conjugate movement. The things that you're looking for is any type of nystagmus or lid lag. And then when you assess for convergence, now a lot of people tend to get mixed up accommodation and convergence. So convergence and accommodation are separate. However, if you're documenting PERLA, making sure that you know the difference between accommodation and convergence. There's multiple ways of using the ophthalmoscope. So use whatever works best for you and best practice. So of course, what things that you're going to be looking for is that orange glow, which we call the red reflex. When you're inspecting the ears, inspecting the auricle for redness or lesions, when you look into the ear canal, you're looking for any discharge, foreign bodies. Now, foreign body can also, depending on what demographic of patient you're dealing with, so sometimes kids like to use their ear canal as a nice hiding spot. I've also had the experience of looking in an ear canal and having a little bug looking back at me. So sometimes you'll be surprised what you find in there. You can look for impactions. So cerumen impaction is very common, especially for those that use Q-tips. Looking for any redness or swelling. You want to be able to visualize the tympanic membrane. You're looking at the color, looking for contour, and of course we're at the position of the cone of light. Palpation, you want to feel the auricle, see if there's any tenderness or if there's any lumps or type of masses. You can test for auditory acuity, or their hearing. So you want to test one ear at a time, and you can stand behind the patient about a foot or two and softly saying, whispering a word or a phrase, and you want that patient to be able to repeat that to you. Using the Weber test, you're doing this using the tuning fork, looking for lateralization of sound to an impaired ear. So if that's the case, you'd suspect unilateral conductive hearing loss. In the Rhine or Rene test, depending on how you want to say it, compare time of air versus bone conduction. So if bone conduction is equal or greater than air conduction, then you want to suspect conductive hearing loss. Inspecting the nose, looking for the anterior and inferior surfaces, looking for symmetry or any deformity. Inside the nose, looking at the mucosa, looking for color, any swelling, any discharge, all sorts of polyps. Looking for any deviation of the septum, any inflammation or perforation even. And then using the otoscope, you look at the turbinates to view the middle and inferior turbinates. Okay, middle and inferior. So if you're seeing superior, you definitely have gone too far. Palpation of the sinuses, you want to palpate the frontal and maxillary. So for example, when using an otoscope to inspect inside the nose, which of the following structures is not visible? The inferior turbinate, the middle turbinate, or the superior turbinate, or all of the above? And of course we know superior turbinate. You should only be able to see the inferior and middle turbinates. When you're inspecting the lips, you're looking at the color and any moisture or lack thereof. Are they dry and they cracking, which might be indicative of dehydration. Any ulcers, like cold sores, might be here. Oral mucosa, looking at the color and if there's any ulcers or any nodules in the mucosa. Gums and teeth, again, color. Do they have? They have teeth? If they're wearing dentures, are they partial? Are they bridge? Are they full? Looking at the roof of the mouth and looking for any color discoloration there. Looking at the tongue and the floor of the mouth, again, color and texture. Any ulcers or nodules. And the pharynx, you want to be able to see the soft palate. Of course, anterior and posterior pillars, uvula and tonsils in the pharynx. So this is where you'll have the patient say ah, and then you would be able to note the movement of the uvula, and at the same time you can also assess for the tonsils. Inspecting the neck, looking at symmetry. If there are any masses or scars, any enlarged lymph nodes, making sure that the trachea is in alignment, and of course if there's with the thyroid gland, looking for symmetry. Now for most people, you won't just by being able to look at the patient's neck be able to actually see the thyroid unless they have an issue, such as a goiter, for example. Now when you're palpating the neck, looking for lymph nodes, looking for size, shape, mobility, delimitation, consistency, and any tenderness. You want to make sure that you're familiar with all the locations of the lymph nodes. Some are very easily palpable, whereas others may not be, and they shouldn't be. And of course, if you palpate, for example, the deep cervical chain would be different versus supraclavicular. The supraclavicular ones really should not be palpable, but if you do feel one, that's why it's important to assess here, and at the same time explaining to the patient what you're doing. So you want to make sure you know the differences between what a normal lymph node should feel like versus one that might be cancerous. So benign versus malignant. And when you're assessing for thyroid, there's an anterior and posterior approach. But here you want to note the size and shape and consistency of the thyroid. You want to identify any nodules or tenderness. And of course, if it's enlarged at all, you want to listen over the lateral lobes if you can detect a bruit. But typically, a thyroid should not be palpable.